Hello, I'm Kathy Pike, clinical psychologist and faculty member at Columbia University. I also serve as CEO for the mental health organization One Mind, and it's my privilege to serve as the host for Big Ideas in Eating Disorders for our podcast. Today's session is part of a series of interviews that we're doing with authors who have contributed to the book that Ruth Weissman and I co-edited by the same title, Big Ideas in Eating Disorders. And the aim of the podcast is really to go behind the scenes and hear from authors about a little bit more about their big ideas and how they came to these big ideas and why they matter. And so I'm thrilled today to be joined by Kathryn Peterson and Will Sharp, who are going to talk to us about their big idea. So welcome, Will and Kate. Thank you.
Thanks for having us.
So let's start at the beginning. What is this big idea that you've contributed to the book? And tell us a bit about it.
So our big idea centers upon two diagnoses that describe dysfunctional food intake in pediatric populations, pediatric feeding disorder and ARFID, avoidant restrictive food intake disorder, that contain almost verbatim diagnostic similarity in terms of nutritional and psychosocial impairment. And that's created a lot of confusion for patients, families, and providers. And our big idea centers upon creating a framework that speaks to the relationship between the two conditions in a more meaningful way, including how their presentation changes over the lifespan to reduce this confusion.
So we've got kids who are presenting with very similar presentations. And you as clinicians, you are both on faculty at Emory University in the Department of Pediatrics. Kids come into you and the dilemma for you is, do they present with diagnosis X or Y? Is that the real clinical reality?
That's a huge concern, especially given that the diagnosis and the presenting challenges can really reflect which treatment path we might take with those children or those patients and which approaches are most likely to be successful. So it's helpful on the front end if providers have a really good understanding of the overlap that can exist and then also the distinct differences between those diagnoses.
Mm-hmm. So how did we wind up with these two diagnoses? Can you tell us a little bit of background of it seems very inefficient, right? That we would have two diagnoses that overlap so much. So how did that happen? And what is the utility of having two diagnoses versus one?
That's a great question because I asked the same thing when they came out with PFD. So little history, ARFID came out in 2013 as a replacement and extension of the feeding disorder of infancy, I'm saying this wrong, but I think it's infancy and early childhood that was in DSM-4. Mm-hmm. And I thought it was brilliant. ARFID had a lot of strengths, including adding 3 more manifestations, basically not requiring weight loss being the sole criteria. But PFD came out in 2019. And the reason that the authors came up with PFD is they felt like the limitation of ARFID is you could not have children with severe medical issues who weren't able to eat because of safety concerns or other conditions that created problems with eating, as well as skill-based, like aspiration and other things that make it unsafe for you to eat. And so PFD filled a gap that ARFID did not allow in the diagnostic criteria.
Okay, so ARFID is 2017. It is extremely helpful. You said it's brilliant, maybe except for the acronym, right? ARFID is, everyone laughs when we call it ARFID. But okay, so we got ARFID. It's very useful clinically, but there's this gap. So there's another proposal for pediatric feeding disorder to fill that gap. And in filling that gap, it solved one problem, but created another. Is that accurate? And so, Kate, you said, yes, there is this overlap, but knowing which diagnosis is most fitting actually guides clinical care. So are you then suggesting we should have two diagnoses? And if so, what do we need to do to make them more useful clinically?
Yes, I do think having the two distinct diagnoses is helpful. As Will mentioned, with PFD, it really centers around those 4 domains: medical, the oral motor skill, nutritional impairment, and then psychosocial impairment. So there's those four big domains with ARFID. It's really talking about this hedonically negative relationship with food. So kids who are maybe showing a lack of interest, they don't really show signs of typical hunger or satiety, or maybe they have sensitivity to different characteristics of the food, the texture, the flavor, the temperature, or maybe kids with ARFID have a extreme fear-based anxiety, so they have a phobia of choking or vomiting or something like that. So if you kind of think about those two big areas, you can start to see where if you don't have the proper assessment tools in place or the right disciplines present, you could miss really critical things. So if a child comes in with undiagnosed reflux and you start going about your treatment without attending to that underlying medical condition, you could really serve to worsen the feeding difficulties or create a lot of pain and discomfort for the child. So that's where, really having the right assessment tools in place, the right disciplines there to assess those things at the front end can help navigate. Oh, this is, PFD is likely because this child is experiencing this painful medical condition. And once we address that medical condition, it's likely that the feeding difficulties will go away. So we might approach that very differently than a child who's had this relationship with food that's negative for other reasons, if that makes sense.
Yeah, yeah. So you're both straddling the worlds of advancing our knowledge, right? Conducting research and clinical in a environment that's also a clinical service. And so as you do this work, can you share with us a case where not having the right diagnosis or the lack of tools to figure out the right diagnosis became very obvious to you?
I can give you an aha moment related to that, if that's all right.
Yeah.
So we have, in our practice, we have a GI doctor, a gastroenterologist, and a dietitian team. And they run a clinic with very young infants, babies, that oftentimes have feeding tubes that were born premature. And they were effectively managing their care where they were able to wean them off the feeding tube without needing to come to a psychologist to get treatment. And what my aha moment was they were really treating PFD. They weren't treating ARFID. These kids needed medical management. They didn't need us. And then there's a separate group of kids that Kate and I are working with that really don't need they need medical clearance, but they're medically cleared for oral intake. And our job is to get them past the fear. I think one thing to simplify it, if you think about PFD versus ARFID, PFD it can be thought of as I can't eat because of safety concerns. And ARFID is I won't eat because I'm afraid to eat or I have fear related to eating. And so those two diagnoses are so helpful in our clinical practice because we're seeing both come to us.
And is it always that clear? I mean, these are sometimes little kids, right? Like, how do you get the information you need and have that clarity? Because I could well imagine that it looks like this child is refusing food or has fear, but like Kate described earlier, if that child has a medical condition where eating causes pain, you'd understand why they would become fearful about eating. And then it becomes, I would think, really hard to figure out what's going on. So what are the key tools that you need or that you're proposing we need as a field to be able to diagnose these conditions most clearly?
Well, I think on the front end, as Will mentioned, we have a team of other providers that will thoroughly assess a child upon intake. So when we first meet a patient and their family, we'll ensure they've had, been cleared for safe oral intake. They've had the necessary tests on the front end to be sure there's no swallow dysfunction, or if there is, we are aware of that and we know what parameters to operate within. There's also the medical side of clearance where they just work they're just seen by a medical team to rule out any underlying medical conditions or to treat and address those prior to even being seen by our team. So that's on the front end. We'll know about those conditions through thorough assessment and intake processes. But then we get to that point, though, where take, for example, a child with undiagnosed or unknown food allergies. That's a medical condition that if a child hasn't been eating for very long or is restricted in their diet variety, we may not know whether they have an allergy to a certain food, and that might not become apparent until later. And so we still have to continue, ongoing efforts to assess, but that challenging behavior that sometimes occurs in the meal where they push the food away and they're, not wanting to take bites, it looks the same for young children, especially whether there's a medical condition or there's this ARFID diagnosis. And so it does take a little bit, of a deep dive and thorough assessment through that multidisciplinary team, through ongoing efforts on our psychology team as well to kind of better parse those things apart.
And I'll add our treatment is so effective if it's purely ARFID for these young kids. This behavioral framework embedded in this multidisciplinary program, that if the treatment's not working, we often say we need to reevaluate for medical conditions, because when it's not working and it's clear that the child's not responding the way you anticipate they would.
That's really interesting. As you think about this contribution as a big idea for advancing the field of eating disorders, one of the questions that I have for you is, these are young kids, and if eating is off track, right? If a young child has struggles eating and it doesn't get sorted out in a healthy way, I would be concerned that there is an extended risk developmentally, that they're going to have more trouble as they continue to develop. Is that the case in your view? And do you see getting this right as being significant in terms of reducing risk for later eating disorders?
Well, I think that speaks to the inherent overlap that can happen with PFD and ARFID. So if your PFD is not resolved, you're going to miss out on key developmental windows, like learning how to use utensils, learning how to chew. I just treated a 5-year-old from New York who had severe food allergies, that had never used a utensil before, had never chewed food before. He was neurotypical, but he was so fearful of everything related to eating that he had PFD early on with the food allergies and some of the medical conditions, but he developed ARFID as a secondary aspect of his food allergy. So yeah, I mean, you can miss out on major developmental milestones if you don't eat early on.
As I hear each of you talk about this big idea and the importance of this big idea for the development, the healthy development of young people, of kids, and does ARFID and PDF, how far into the developmental course are you seeing ARFID and PDF, and are there limits around age and when you would diagnose this?
So pediatric feeding disorder by its nature requires that you be a pediatric individual. So like it stops at 18. It doesn't mean you can't have PFD in adulthood. You could have unresolved PFD that grows and you grow up and you still have it. ARFID, what's interesting about ARFID is it basically is a lifespan disorder that says it can emerge during infancy all the way into adulthood. And that I think that speaks to what I was talking about previously, of this idea that ARFID's co-opting a biological imperative to avoid things that cause pain or discomfort. And so the challenge for us, I think, is figuring out diagnostically when it's useful to use both diagnoses, but when there's clear overlap, or when you really pivot to say, for us, we want PFD resolved before we treat the ARFID. That's really important for us. But it's not always clear that ARFID and PFD, which one it is when we're treating food refusal.
Mm-hmm. So as you've done this work and as you've been developing this big idea around the need to have greater clarity of diagnosis and develop treatment protocols accordingly, is there a piece of the big idea that one of you is more passionate about than the other? There's a piece that Kate is really, driving your engagement around this big idea that might be a little bit different from Will's?
Yeah, absolutely. I think, Will and I, the interesting thing about our collaboration is that we come from pretty different backgrounds. I came from a very behavior analytic background, and there's a lot of evidence to support the use of behavior analytic intervention for treatment of ARFID. Mm-hmm.
Explain what does behavioral analytic mean?
Yes. So that is, there's a whole profession now that's grown out of the science of behavior analysis. So that's when you think about operant learning principles or Skinnerian psychology, when you think about early on in the 50s, 60s, that kind of work, looking at how an individual learns and how behavior is reinforced and continues and how behavior naturally contacts punishers and things like that. So it's the science of behavior analysis that's now become a whole profession designed around effective intervention and assessment, most often with individuals who have developmental delays or children with genetic disorders like autism. So that's where behavior analysis is most often applied. It's often applied to other areas like feeding disorders, although it's less known that this is sort of a subspecialty of our field. And when I got into this area, it was really fascinating for me because I had been working mostly with kids with autism. Maybe I had been working on teaching communication skills or other academic activities and skills. And then when I had some experience working with children who were not eating a wide variety of food or were not eating enough to grow, and we were able to use these treatments to really rapidly see effects. It was just astonishing to see that you could teach kids new skills and you could expose them to the appetitive properties of food, and then they would start to like eating. And it's an exciting thing to kind of jump into that side of the field. And so there's been a lot of research on behavior analysis and how those set of tools can be really effective to increase kids' motivation to want to eat, to maybe gradually teach new skills and things like that. And so that was largely where I came from. And I often operated in very small programs. So I had the luxury of really diving into each child and individually assessing what's happening and spending a lot of time in there. But that's great when you have that opportunity, but it really doesn't do anything at all to address the larger needs of the population, the prevalence that we're talking about. And so in joining forces with Will, he has been instrumental in pulling me out of the weeds a little bit to kind of see these bigger pictures, and where even things like this diagnostic framework can really help set us up for scaling up services, for getting more folks trained to be able to do this safely and effectively, and to address that unmet need of kids getting the services that they require. So I think I was kind of in this little bubble, and now I'm being able to really expand that view and see how this work can really generate to other kids and other families and providers.
How about you, Will?
So it's interesting. I want to leap off of Kate's description of ABA, or applied behavior analysis. So I'm a pediatric psychologist by training. I dabbled a little bit in ABA during undergrad. But I landed in this program here in Atlanta that was a hardcore ABA behavior analytic feeding program, serving these young kids with developmental and medical conditions. And Kate didn't describe it completely in terms of how hardcore it is. They take bite by bite data on like 20 different variables, from like acceptance to swallowing to crying, and they use that data, they graph it, they look at, they say I guess I do this too now, but we look at it at a very discrete level to make decisions regarding what to do next. What I did was I think that there's such an unmet need in the community that we know of, that I started looking for patterns across patients where we could package up manuals and standardize the care so that we could scale it. And so what we built here in Atlanta is the largest program of its kind in the United States, maybe the world, not to be too, whatever, braggadocious, if that's the word. But we built a huge program in order to see if we could scale these treatments and bring them to broader communities. And so our hope is that by improving diagnostic systems and creating standardized interventions with treatment manuals, that we can help more and more kids throughout the United States and hopefully the world. Maybe ambitious. I don't know. Go ahead.
Yeah. We asked authors, and we invited authors who have big ideas to participate. And this is a big idea, in that what I'm hearing from both of you, knowing the population you're trying to serve, both from a research perspective and a clinical perspective, that there are critical issues around improving diagnosis and assessment that will further inform care so that you have appropriate, effective outcomes. And there are several steps, almost like the work that you do with ABA, very, careful steps along the way, that there are several steps in your big idea that each one will amplify your capacity to have the impact that you want to have, right? From more careful understanding of clinical presentation, which depends on more specific assessment, which then permits more tailored clinical care. Is that accurate?
Yeah, and I will add, and I think Kate, please jump in, but one of the things that happened with ARFID was the introduction of ARFID led to more older neurotypical patients landing on our doorstep. So these were 9, 10, 11, 12-year-olds that could talk, and they could feed themselves.
Mm-hmm.
But they had these really narrow restrictive diets. And our ABA model of treatment really didn't align with that. You don't do this discrete trial and not that we don't talk to our patients, but our very young kids, our infants, that's a completely different profile than a 10-year-old. And so we had to start adapting our treatments and really creating new models of care that we're now testing and refining. And what's interesting is we went to our eating disorders colleagues, the ones that, are treating using CBT to treat, older adults and adolescents, and started to learn from people like Jenny Thomas about what she's doing and Cameron Eddy and the work they're doing at Harvard, so that we could adapt and serve more kids. And I think there's a really big opportunity to merge the two worlds in a really meaningful way to help all these patients that didn't have a diagnostic home before ARFID.
As you look ahead, what are the top priorities for you in moving this big idea forward?
I think some of the initial steps, to continue to increase collaboration with different folks who are doing this work to make sure that folks are on the same page. That to me seems like the most critical first step, is to really align our efforts and understanding of the diagnostic framework. And then to, as Will mentioned, to start to take efforts to really, scale up consciously. What are we going to do to expand our training efforts? What are we going to do to, provide opportunities for experiential learning for different disciplines to come, because as Will mentioned, this is one of the biggest programs in existence, and there's only, I think, 16 total programs in the US that address ARFID and PFD in this sort of intensive manner with multidisciplinary support and all of that. So small number of folks, so really starting to scale that number upward and getting more providers doing this work. But I guess, and Will has some very, specific thoughts on future directions as well.
I do. But, I think the more immediate concerns, okay, that was very well said. I think the most immediate thing that needs to happen is that any refinement in future diagnostic systems for PFD and ARFID, they need to reference each other in a meaningful way. That is, they actually need to speak to the fact they each exist, and then define, when the overlap occurs and when they're distinct from each other. And then what we plan to do is really work on creating standardized training for community providers, because, the 16 programs that Kate referenced, and we have a paper that kind of describes this treatment landscape, they serve collectively 1,000 kids a year. So about 1,000. We guesstimate, if that's even a word, we guesstimate that there's probably closer to 1 million kids that need access to care. So this is a drop in the bucket for what needs to happen. And most children are being served in community settings by speech language pathologists and occupational therapists they're basically training themselves on how to treat this without any formal educational pathway. And so we need to develop better tools and systems to help providers care for these patients.
Yeah, what you're describing is so critical in terms of workforce, because otherwise we have people making their own judgments around whether it's pediatric feeding disorder or ARFID, and not everyone is going to make the same call if we don't standardize the criteria and if we don't make that training available. So really, really critical, because if we don't get that right, we can't know what the prevalence is, because the data aren't going to be very good in terms of what we date. If it's bad data in, it's not going to be great data out, or So it makes me think about how widespread the conversations with young kids are about, picky eaters. And how do you distinguish a sort of normal picky eater from somebody who's got a clinical condition? And I guess you must be asked this at every cocktail party by every parent of young child, but how do I get my kids to eat these, eat their vegetables? What do you say to the entire population around this phenomenon, and what's good guidance there?
Yeah, I think one thought, you're absolutely right. That's a very common thing. It's a normal part of age typical progression. We expect to see kids, especially in their toddler years and even into early school age, be maybe a little selective. Maybe they don't want to eat their veggies or finish the food on their plate, or parents struggle with some picky eating that emerges. But most often, those types of patterns resolve. There's been some studies looking at sort of just general norms and how kids, as they age, peers can influence their eating behavior, or their preferences start to go in different directions. And so there is a very typical expected progression. I think what I typically lean on is when that picky eating really starts to impact a child's health and nutrition to the point where they're experiencing other illnesses, or it's affecting growth, or even that it's causing a lot of pervasive stress among the family, that they're having difficulties at every mealtime because of challenging behavior. Or maybe my child's willing to eat a lot of different food, but they take 2 hours to eat because they're really inefficient. The impact that it has on the family and their well-being and their ability to kind of carry out typical routines is what we tend to look at as crossing over into the realm of, we may want to look at a treatment for this. Because there are, my daughter, I'm going into her toddler years being like, we're going to get through this. We're going to come out on the other side eating vegetables and loving them. But she's gone through her own little journey, and she's a little selective, but I'm okay with that because she's meeting her needs. She's getting foods from all the food groups. She's willing to try new things. Those are the kinds of things that I'm looking for. And I think, going back to one of even your earlier questions, I think, increasing awareness too for pediatricians and doctors' offices, and what are the red flags that families should be looking for to maybe know to access services at an earlier point versus I just got to kind of ride this out. And even some general strategies for teaching families, these are the ways to get through these challenging points. Don't stop introducing new food. Don't encourage it. You don't stop encouraging exploration just because maybe they turned it down once or twice. So there's a lot we can do on that end of the spectrum too, not just the truly impacted health, but also that picky eating side.
Yeah, we can be the greatest scholars in our fields, but as we have children, there's always more to learn, right? There's a way of learning that happens that doesn't happen in the books.
Yep.
Yeah. So Kathy, you also asked, like, what's your cocktail party kind of explanation to families? Our treatment model really focuses on two things. I'm going to make it way oversimplified, but the first thing we do is we want to restructure the meals and the dynamic between the parent and the child. So our goal is to reduce conflict around eating. So a lot of families that come to us, there's a lot of pressure coming from the parents to try to get the child to eat, and there's a lot of resistance on the part of the child to not eat those foods because of that. So that reducing the conflict, teaching them new ways to interact is really powerful. I can't go into the weeds of how we do that in terms of time right now, but that's the first step. Then we change how we present foods. And so, one of the things we do in our clinic is we do a home baseline, and we say to the parent, show us what it's like when you try to get your child to eat something new. And what they do almost, 100% of the time is they present like an entire bowl of green beans. And that entire bowl of green beans, that communicates something. That communicates like, I have to eat that entire bowl of green beans. So a lot of our interventions involve changing how we present the food. Instead of a bowl of green beans, it might be a half a green bean or a pea-sized green bean. And what happens is that reduces the child's defensiveness because what's been asked of them has changed and they're much more receptive. I've had children start laughing when we start to give them, and the third part, there is a third part. We give a lot of choice if possible. When we allow the child to tell us what food do you want to start with, as opposed to being told they have to try these things, they're collaborators in the process as much as they can. And that element of changing the parent-child interactions, changing how we present foods, and then having the child involved with their own treatment plan has been a really powerful way for us to change, to develop new treatment models.
Yeah, fantastic. Right. The last piece in terms of bringing agency in a moment that is flooding emotionally, potentially, is so powerful. Yeah.
Yeah.
So shifting gears a bit, wondering if you can share how you got to this field of study, and if you roll back before you were experts in this area and really leading the charge in our thinking on how to understand these pediatric feeding disorder and ARFID and these conditions in kids, I imagine there was a time when you thought you might be doing something else in your adult life. What was that? What might that have been for you?
There was a time in my early adulthood where I always knew I wanted to be working around children because they bring so much joy. It's a fun thing to get to work with kids every day. I always thought I would work somewhere in the medical field and being able to, in healthcare industry. And I mentioned before, I was in behavior analysis. And so I really envisioned my career centering around providing services for children and families affected by autism or children seeking services for autism. And when I first, was able through just a random rotation as an intern, I got assigned to a feeding program. And I saw within 1 or 2 days, a little one who came to us who'd been tube dependent his whole life. He's around 3. So dependent on a gastrostomy tube for all of his calories and nutrition, had been pushing away food since very early. I saw him take his first bites, and I saw him actually start to show some enjoyment on his face. And so this is one of those PFD kids that had some complex medical history, but as soon as he actually was exposed to the food and started really experiencing that, just watching that evolution happen with him and watching his parents experience the joy of something that seems so simple and routine for us, just eating our lunch and eating our breakfast, and we do it every day and we don't put much thought to it. That moment was just so powerful for them.
Sure.
And it completely shifted my path, and I haven't looked back since. It's just such it's a great thing to find so much reward in your work, but it is truly rewarding every day to get to work with families and have that moment so often. And it happens, as Will mentioned, our treatment is so effective. And these kids, really benefit in so many ways, and the families too. It's just exciting. And so I think the work itself is exciting. The future directions are invigorating too, to know where we can propel the field forward, and next steps to take are also, super interesting and exciting, but it's been a real joy.
Wonderful. How about you, Will?
Yeah, so I'll piggyback on some of the things Kate alluded to. I like hitting grand slams. I mean, who doesn't like hitting grand slams, right? And so that's cool. So I was trained as a neuropsychologist. I was going to be like a neuropsychology person. And I went to my fellowship and my internship, and I was doing hardcore, testing of really complex cases. And I figured out I didn't like it. And I didn't like it because I'd test a bunch of kids and I'd write these great reports. And there was, I guess, this is just my own feeling, nobody ever read the reports or did anything I was recommending. So I kind of felt like it was like this dead end of like, I'm going to write a report, do another test, and nothing's going to happen. And so I had a colleague named Colleen Lukens, who I still, I meet with her every Friday. So hello, Colleen. So Colleen came up to me and said, "You don't look very happy here." And I said, "I'm not." And she's like, "You should try feeding because I think you're going to like it." And so she introduced me to feeding. And then when I went to look for jobs, there happened to be an opening here in Atlanta. And the previous director said, "You don't have much of a background, but I'll take a swing on you. You seem like you'll give it a shot." So I basically self-taught myself this field, as opposed to like, I think, Kate, you grew up in it. I landed at a job, didn't know what I was doing, and basically read every article that you could and wrote a meta-analysis after I read that article, read all the articles, and then started, developing and learning and changing the treatment model.
Wow, how exciting. So you feel like you landed in the right place.
I mean, we are hitting grand slams. Like the dopamine hit from like the level of progress is amazing.
Yeah, it's so gratifying, I'm sure. Yeah. It's fantastic. And as you said, Kate, highlighting for the kid, but also for the whole family. Your intervention is not just impacting one person, but really impacting a whole family.
Yeah.
So last question for you. If you could have dinner with anyone, we've been talking about feeding and eating, and let's imagine this delectable feast and dinner with anyone in the world, alive or who has come before us, who you do not know. Who might that be?
I had one thought of this. This is a hard question. There's so many fascinating options I could select from. One, I was chatting with a former student of mine actually recently, and I was talking a little bit about this, and I was thinking to myself, like, gosh, who would I have dinner with? And she said something super interesting, and I agree with her that I think it would be really cool, and we can't because we have dual relationships. We can't go back and see our kids in like 10 years. But I do think it'd be fascinating to sit down with a family who's gone through our program and have dinner with the kids that have come through and to see like how far they've come. Like that would be like a cool twist on this, where it's not like a famous person, but it's to see like firsthand what effects this has had, because we do not the best job at long-term follow-up with some of our families, because once they receive our care, they go on and thrive, and we may lose time. Yeah, but I think it'd be really awesome in 10, 15 years to meet those kids as adults, see what they're doing, see how their lives have changed and in positive ways because of eating, and be able to share that joint experience with someone like that would be really neat. So that's like kind of like a directly related to the work I do. I think that'd be fascinating. Otherwise, I'm going to go back to Skinner. I think I would go back and see what it would be like to have dinner and pick his brain about learning and and how this whole science emerged. And I think that would be who I select.
Wonderful. Thanks, Kate. How about you, Will?
Kate has such a better answer than I am, so mine is not going to be as grounded in anything that is meaningful to the work we're talked about today. If you hang out with me long enough, I don't know, Kate, I walk around with earbuds and listening to music all the time. And so I would probably have dinner with whatever artist at the time I'm really into. So like I was thinking about, if he's listening, Tom York from Radiohead, like that would be amazing. So if anybody has connections, like I'd love to sit down with Tom. But really it depends on what I'm listening to and what I'm into at that moment. Wonderful.
Well, thank you both so much for sharing your big ideas, for taking us behind the scenes a bit in this podcast. Your chapter is really so audacious and important in terms of the field and moving the field forward. So we're extremely grateful that you contributed your chapter to our book. And I'd encourage any listeners to take the time to read the chapter. And thank you for the work that you're doing and the interventions that you're building that are really changing people's lives for the better. So thanks.
Thank you.
Yeah, thanks for having us.